welcome to the EAU podcasts. In this episode, UROONCO Kidney Cancer Associate Editor Dr. Palumbo interviews Dr. Rescigno on single-agent TKI in selected patients with metastatic renal cell carcinoma.
Hi everyone, this is Carlotta Palumbo from the University of Eastern Piedmont in Italy. I'm working as Associate Editor for the UROONCO Kidney Cancer platform. I'm here at the EMUC meeting in Prague, and I'm sharing this interview with Dr. Pasquale Rescigno. He's a medical oncologist and a senior clinical lecturer at the University of Newcastle in the UK.
Good morning, everyone, and it's nice to be with you here in Prague.
So Dr. Rescigno actually had the hard job to defend the TKI monotherapy in the metastatic RCC session. So my first question for you is, what is the rationale to still consider TKI monotherapy in the era of immunotherapy combination in metastatic kidney cancer?
So if you look at all the trials they compared in immunotherapy plus a TKI versus a TKI, in all the trials they always selected sunitinib. They used to be the standard of care a few years ago. You will see that when you look at the Kaplan-Meier data and the rPFS data, there is a backbone of 20% of patients. In all the trial is always the same. 20% of patients on sunitinib monotherapy, so on TKI single agent, that stay on that treatment for at least 2 to 3 years. So there is a 20% of our population metastatic renal cell carcinoma that will benefit from what we call de-escalation now, because it's a really fashionable word, they will benefit from a de-escalation treatment. Beautiful, immunotherapy and TKI, they improve our survival in the majority of our patients, but there are also some toxicity that are immunorelated more than TKI related. So GI toxicity, skin toxicity, thyroid function alteration, glucose alteration, that could be quite a problem, and we are seeing more and more frequently. And most of these immuno-related adverse events require high-dose steroid to be treated. So yes, they improve overall survival, the combination of IO and TKI, so anti-PD-1 or PD-1 plus TKI, that comes with some costs. So if we are able to identify who are 20% of the patient that will benefit from single-agent TKI, that will be the best of the world, because we can reserve a safer and more tolerable treatment to patients that would not need the addition of immunotherapy to a TKI. So as you said, it's really difficult. It's challenging to defend single-agent TKI, but I truly believe that there is a subset of metastatic renal cell carcinoma that will benefit from TKI.
So can you describe now the ideal candidate of TKI monotherapy, and do we have some clinical or biological features that can help us in identify this ideal candidate?
So if you look back at all the data from clinical trials like pembrolizumab and lenvatinib or nivolumab and cabozantinib, all the registrative trials, we will see in the subgroup analysis data that a patient that seems to that potentially could do better on single-agent TKI could be the patient with favorable risk according to IMDC score. But beside that, now we have more evidence about biomarkers. One of these biomarkers seems to be genomic signature. So Mozart was the first one analyzing the data over the Motion 150 trial to find out that there were patients expressing different genomic signature. One that was identified as an androgenic signature, and the other one that was identified as immunogenic signature. That was developed based using transcriptomic data and using a panel around 30 genes. But now we know that there are new data coming from the Da Costa group, where this panel was extended to 66 genes that seems to identify even better androgenic signature versus immunogenic signature. So that could be potentially used in the future as a biomarker. And I say this also because now we have a new trial called OPTIC trial, and some of these data were presented at ESMO this year, where they were selecting patients based on androgenic or immunogenic signature, and they were given different treatment. The only problem with this trial is that they didn't select didn't choose as a treatment an arm with a single agent TKI, but I have an arm with a TKI and also with nivolumab and cabozantinib for the angiogenic signature, and I have an arm with nivolumab and ipilimumab, so the double IO for the patient with immunogenic signature. They presented the data about the angiogenic signature, and the interesting thing is that yes, there is a high concordance between the angiogenic signature and the favorable risk according IMDC score. So that justify what I was telling you just 1 minute ago about selecting patients for single agent IO using the IMDC score. However, there are patients with angiogenic signature that potentially could benefit from single agent TKI, also in intermediate risk and some also in the poor risk. So potentially in the future, using this transcriptomic data, we could select our patient for single agent TKI. And the good thing of using transcriptomic data based on the data that were presented at ESMO on the OPTIC trial is that the failure rate for the transcriptomic analysis is only 20%. So there's a good chance that we could derive some, information using the sample of our patient with a higher success rate.
So that's great. Now try to move on. Let's imagine that we were able to select the ideal candidate. So you as medical oncologist in your clinical practice, which TKI would you prescribe to this patient?
So there are a few meta-analyses comparing different TKIs. The ones that are available on the market are sunitinib, pazopanib, axitinib, cabozantinib, and tivozanib. So in UK, where I practice, we have the possibility to use tivozanib as a monotherapy in the first line of metastatic metastatic RCC, and I use it quite regularly for patients with favorable risk. And tivozanib has a really good toxicity profile. It's extremely manageable, and what I see in my practice is quite effective as well. And these are the same data that come from the meta-analysis that I was telling you. So if we have the chance, I guess as a single agent TKI, tivozanib could be a good option.
So again, thank you very much for being with us and for sharing with us your expertise. So really, thank you very much.
No, thank you for having me. It was a great discussion. Thank you.
Thank you for listening to EAU podcasts. To keep up to date with kidney cancer developments, visit our educational platform, UROONCO Kidney Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.